ingredients that we have. And then hopefully at the end of this talk, you'll be able to describe 2 things that you can do to advocate for your nutrition, because I'm a big fan of advocacy. All right, so first off, I want to say that diet matters in IBD. A lot of the times when I meet with people in clinic or during one-on-one sessions, I hear from them that they've been told that diet doesn't matter. They've been told to eat what doesn't hurt. And they can basically, like, diet doesn't really influence their disease course at all. But we do know, and we're learning more about the role that diet plays. We know that it can have a profound impact on how you feel, so your symptoms. It can affect your disease outcomes. It can help you to respond better to your medications. It can help you to have, if you need surgery, it can help you to have better outcomes associated with that surgery. It can help to decrease chronic disease risk. So outside of IBD, it's helpful. And then, of course, diet is an important aspect of quality of life. And unfortunately, what we know about the relationship that a lot of people with IBD have with diet is that food avoidance is common. And we see high rates of food avoidance even when people are feeling well. And to some extent, food fear or food aversion is a natural response, right? If we eat something that causes us pain or eat something while we're having a painful episode or symptom, we can associate that feeling with the foods that we're eating. Take, for example, eating raw or undercooked foods and getting food poisoning. You're likely going to have a little bit of an aversion to that food that you associated with that food poisoning episode. People also will find that some foods can consistently trigger their
There's a
symptoms.
lot to know about all this stuff, and a lot of it is it depends.
I'm sorry?
Yeah, and you do have to taper off a 6-10P.
Oh, Ralph. Okay, you don't have a question. I think you're just unmuted. Um,
You should look it up. How's that for advice? Look it up.
okay. Um, And there's also some medical advice for patients that they receive about avoiding certain foods. If they, for example, come into the hospital with an active flare, a lot of times people are going to be told to restrict their diet or not eat fiber or certain foods. If the same happens if they have stricturing disease or a complication of Crohn's. And same can happen if they have surgery. A lot of people are told to go really slow with diet after surgery or limit certain foods in their diet. I wanted to share this review with you. The authors really looked at about 19 studies trying to get a better sense of how people with IBD how their diet was influenced by their disease. And what they found was that people with IBD tended to eat less amounts of energy, fiber, folate, and calcium. And then when looking at specific food groups, they ate less of breads and cereals, legumes, fruits and vegetables, and dairy. And so compared to people without IBD, patients with IBD tended to eat significantly less foods overall and less fiber overall. So why is this important? Well, again, diet affects quality of life. It also affects your nutrition status and your disease outcomes. So, and it can lead to malnutrition. And this is one of the biggest drivers of malnutrition that I see in my practice is related to this food avoidance. And we see it in studies, high rates of people change their diet after being diagnosed with IBD, 67%. Reported in this study, 77% avoid some foods to prevent disease relapse, and 86% of people avoid foods with active disease due to fear of their flare worsening. So diet does matter. We know that people with IBD recognize this. And so my goal today is to help guide you through some of the diet therapies to help address, that relationship that you have with food and uh, to help stimulate some questions that you can take back to your provider and see how well you can address nutrition for yourself. So food fears can, again, be a normal response, but sometimes it becomes problematic. So if you're finding that, eating is becoming overwhelming, scary, if it starts to interrupt your social life, if you have a really limited amount of foods that you consider safe that you can eat, that's when we start to really worry about its impact on you overall as a person and on your health. And so this is where that multidisciplinary team can be really beneficial. Talking to your dietitian, your social worker, your provider is really important because you are not alone if you are experiencing this. We do see this. And we have resources and support to help you reestablish that healthy relationship with food. So if this is something that you're experiencing, definitely don't stay silent and talk to your team so that you can get help. This is, I have on the screen some of the factors that can increase risk for malnutrition in IBD. Again, inadequate intake or food aversion, food restriction can be one of the primary drivers, but there are many other drivers that are associated with malnutrition in IBD, including gut losses, maldigestion, malabsorption, surgery. Sometimes specific medications can increase your risk for malnutrition. And so this is important because here on the right-hand side of the screen, I have listed the, clinical outcomes and disease outcomes that we see when people have malnutrition and IBD. And that's why it's so important to address it. So we want to prevent growth failure. We want to help you to respond better to your medications. We want to decrease your risk for non-elective surgery. If you get admitted to the hospital, we don't want you to stay there for a long time. If you have surgery, we want you to have good outcomes. And then, of course, malnutrition increases costs overall. So this is why it's so important to address in our in people with IBD. So before we get into the diets, I just want to talk a little bit about remission because there are different layers of remission. The first layer is kind of the lightest layer, and that is called clinical remission, and that's when you're feeling well. So we want you to feel well, but what we see is that sometimes in IBD, symptoms don't always correlate with what's going on inside with that disease activity in your gut. So sometimes you can feel really well and have inflammation on the inside. So that's why it's important to look at deeper layers of remission. The next layer would be biochemical remission. So looking at things like blood or stool markers to see if there's any elevation or if they're normal. That's important to look at. The next layers up would be endoscopic remission, which is where when you get your colonoscopy, everything looks good to your doctor. It looks normal, no ulcerations or inflammation seen. And then the deepest level of remission is called histologic remission. And that's when they take one of those biopsies when they're doing the colonoscopy and they look at it under a microscope and they see no inflammation there. The current treatment target right now is endoscopic remission. So when you're started on a medication or a diet therapy, this is kind of like what the goal is for getting you to remission is endoscopic remission. And if we can get you to histologic remission, that's even better. The deeper your remission, the better the outcomes we see. So
A
that's why
question.
it's important to look at all the different layers.
I have I have
Yeah.
a question, Kelly. Um, okay, we have ultrasound right now. What is the how accurate is ultrasound compared to calprotect, for example?
Great question. It probably falls like right around here. So intestinal ultrasound is becoming more popular in the United States. And I need to update my slides. Thank you, Kathy. But yeah, it'll probably fall around here. It's a quick, non-invasive way to assess disease activity. So your doctor is able to see if there's any inflammation in the intestines. It's not as accurate in people with a pouch and in other scenarios, but I think that, that would fall right around here.
Where?
Between biochemical remission and endoscopic remission. Sorry, you probably can't see my mouse, but it's like just below endoscopic remission.
So I
Call
have question is like so calprotect is more precise than ultrasound, or ultrasound is more
No,
precise?
no, no. It would be after the calprotectin, before endoscopic remission.
Okay, so it's more accurate than calprotect, basically, right?
Yeah, well, with IBD, we like to look at a variety of factors. Fecal calprotectin doesn't always, people don't always mount a response with sedimentation rate or CRP or fecal calprotectin. So it's important to look at as many factors as possible to assess disease activity.
Okay,
Great question.
thanks.
So is there a perfect diet for people with IBD? The number one question people have for me when they see me is, what should I eat? And what I will say is that there's no one diet approach that I give to all of my patients. We do know that diet can affect the microbiota, which is the bugs in your gut, the metabolome, your immune response, and your mucus layer. What we know about diet is that evidence suggests that a Western style diet, which is a diet high in meat and fat, high in food additives and emulsifiers, and low in fiber, increases risk for IBD disease onset and also worsens disease activity. Ultimately, diet should be individualized. This should be a conversation that you have with your provider, and based on your nutrition status, what type of IBD you have. Remember, there's Crohn's and there's colitis. Those are the two kind of major types of IBD. Your disease activity. Do you have active disease, or are you in remission? Do you need surgery? Because there are certain things that can help you to prepare for and recover from surgery. Do you have access to a grocery store and the things you need to follow a therapeutic diet? What about your cultural background or your religious beliefs? And of course, your relationship with food. Those are all important things to think about and assess when we're talking about diet for IBD, and one of the major reasons why there is no one diet approach. Diet restrictions and defined diets are not for everyone. For example, some people that I probably wouldn't put on like a really restrictive diet would be somebody who's severely malnourished, somebody who has an eating disorder, or just somebody who doesn't want to follow diet therapy. So this is a shared decision-making process that you have with your provider and to help you find what the best approach for you is. Clinical guidelines, currently, medical guidelines recommend a reasonable nutrition approach to be a Mediterranean diet for people with IBD. A lot of people have been told that a low fiber diet is best for IBD. And I think if you Google diet for IBD, you'll get a lot of low fiber, sometimes like, other diets that aren't necessarily evidence-based will pop up in that Google search. But what we know about fiber is that it's really beneficial for our patients. That's what we're learning. Fiber helps your microbiome produce short chain fatty acids. Those are really anti-inflammatory, especially if you have inflammation in your colon. Short chain fatty acids are really good for your colon, help to keep it healthy and help to reduce inflammation. So fiber is so important. And what we're learning is that people actually feel better when they eat more fiber. So there's been a shift since I've started working in IBD about 12 years ago, where we used to say low fiber. Now we say, let's talk about how we can incorporate fiber in a way that doesn't worsen your symptoms. So The only caveat here is that if there's a complication with IBD, such as a stricture, or you've had a history of obstructions, you'll want to think about altering that fiber texture so that it's soft. And may want to add in some nutritious fluids like nutrition shakes. But other than that, trying to get fiber in is really part of the general recommendation now.
I have a
Um,
question. I know you're saying strictures, but what about for somebody who has a lot of scar tissue after surgery and you don't know where it is and you're afraid of obstructing from the scar tissue?
yeah, that's a great question.
I'm sorry, not scar tissue, adhesions. Well, I
Yeah,
guess scar tissue and adhesions, yeah.
yes, the same would apply there. It's a little harder though because sometimes with adhesions or is there's like tethering of the bowel that kind of gets kinked at some times, and then that kink kind of opens up. So it's less related to, the foods that you're eating and more just those adhesions that can cause that obstruction. But if there's are a lot of adhesions that are pulling the bowel in ways that increase that, sorry, not increase, decrease the luminal opening that kind of narrow that area for food to pass through, then you want to maybe consider those soft foods as well. So that's a great question. Adhesions, strictures, and anybody with obstructive symptoms may do better with a soft diet or nutritious fluids.
A question. Okay, so do you recommend Mediterranean compared to a CD diet for the IBD?
We will get to that.
Oh, okay.
It's like I planted you here. You're perfect. You're keeping us on track. So these are some general recommendations for nourishing yourself during a flare. This is not like evidence-based in terms of like we have randomized controlled trials showing that this is what you should do. It's more like what we've learned from patient experience and what I've learned, at the bedside with my patients that tends to help improve symptoms or improve nourishment when people are flaring. So if you're experiencing lots of pain, discomfort, nausea, smaller and more frequent meals may help with nourishing. Modifying fiber type and texture can be helpful. So I'll talk about that in the next slide. A high calorie, high protein diet is really important because when you have inflammation in your intestines, even if you're eating the same amount that you normally eat, it's like you're kind of running a marathon just sitting in that chair. So, or in the hospital bed, because inflammation just drives up your energy needs and your protein needs. So you need more than you would normally. So this is a great time to maybe add in some nutrition supplements or some nutrition shakes because those are generally much better tolerated. And then sometimes people report that they feel better limiting things like lactose or spicy foods, fatty foods, caffeine or alcohol. So that may be helpful as well. And sometimes I ask my patients to keep a food or symptom log for just a couple of days to kind of help them identify some safe foods. I like to, I don't like patients to keep food logs for a long time because that can be really anxiety provoking. But just for a couple of days, it might help to show some correlation between, how they're feeling throughout the day and their symptoms and then what they're eating. But don't forget the basics. Deep breathing can help to activate your parasympathetic nervous system, which is your rest and digest mode. So remember, when you're sitting down to a meal, try to do a couple of rounds of deep breathing before you get started on that meal. Just helps with digestion overall. Try to eat balanced meals, and if you can, home cooked meals. People just tend to feel better eating home cooked meals. If you can chew your foods well and eat slowly, that is actually the start of the digestive process. It helps to send signals from your brain to your gut to get ready to digest your food and absorb it. Helps to regulate motility and hormone secretion and lots of things that help to stimulate a good, healthy digestion. So chewing your foods well is really important. And then, of course, staying active as much as you can. Don't push yourself too hard, but just walking around the block is going to be really good for your metabolism and helping to maintain your strength and just helping your immunity as well. So back to that fiber. Do you need to limit fiber if you're flaring? Well, I'd like you to think about the fiber type that you're eating. We generally classify fiber into three main types based on its solubility, viscosity, and fermentability. So when I'm talking with patients and they tell me I have diarrhea, we talk about some soluble and viscous fibers that can help to slow down their diarrhea. Soluble meaning the fiber dissolves in water, and viscous meaning it kind of helps to thicken the stool. So kind of helps to slow down transit. So beans would be a good example of that, like a hummus or a bean puree. Oats are really good for that. Maybe like a rolled oat, cereal in the morning, peas, avocado, sweet potato, pears, turnips, and then psyllium is actually like a fiber supplement that you can add to your diet as a way to help to slow down diarrhea. Really great soluble and viscous fiber that doesn't worsen GI symptoms.
I have a question. This like in the SCD diet, lots of them is not allowed, like a psyllium. But I hear like psyllium is a food for bacteria, is a good bacteria also. So it's like really confusing.
So this isn't specific to SCD. We'll talk about SCD in a second, but fiber is going to feed bacteria. As humans, we can't digest fiber. That's what our bacteria help us to do. And with that digestion by the bacteria, it generates nutrients, including calories, and then micronutrients like vitamins. So fiber will feed bacteria and help to rebalance dysbiosis that we tend to see in IBD.
Why in SCD we prohibit like psyllium, for example, or all those good fiber?
We'll talk about that in a second.
Okay, thank you. Sorry.
Of course. Insoluble fiber may be helpful for constipation. So if you're having a flare, sometimes people experience constipation, especially my patients with ulcerative colitis who have inflammation near the rectum. They can feel really constipated. So low fiber diet can actually worsen their symptoms. So insoluble fiber adds bulk to the stool. That's going to be your peels of fruits and vegetables, your whole nuts, your whole seeds. Some examples: whole wheat flour, wheat bran, cauliflower, and green beans. Sometimes people experience gas and bloating, so fermentable fibers might worsen that. So we talk about decreasing things like beans or inulin or wheat dextrin or oligosaccharides. And then if you have psyllium fiber can be really helpful for diarrhea, constipation, or fecal incontinence because it's a soluble, non-fermentable viscous fiber. So that fiber additive can be really beneficial for a lot of different symptoms. And then speaking about texture, this is a kind of a way to represent visually how we talk about fiber texture for somebody who's flaring or experiencing obstructive symptoms. On the left-hand side of the screen, you'll see the red column, which is more pureed foods and nutrition liquids. Examples would be creamy nut or seed butters, fruit or vegetable purees, tofu, cream of wheat or rice, refried beans or hummus, mashed potatoes, souffles, smoothies, and then those pre-made nutritious shakes. Sorry about that. And then transitioning out of a flare, more fork, tender, and soft foods, such as jarred or canned fruits, soups with cooked vegetables, and then when in remission, more of those whole foods, the salads and whole grains and whole beans and nuts and seeds. This is a recommendation from our one of our medical societies on nutrition and IBD. They recommend using nutrition supplements when medical nutrition is indicated. So when we see that people are malnourished or not able to eat, we want to really rely more on those liquid nutritious supplements because they can really help our patients in a variety of ways, including addressing malnutrition and reduce muscle mass or sarcopenia. It can help with inducing remission. It can be used as combination therapy along with your medications to help get into remission. It can help you to maintain remission, and then it can also help with preparing for or recovering from surgery. So these nutrition supplements are really beneficial, and I use them a lot in my practice. So let's move on to diet therapies for active IBD. So if I have a patient coming to my office with an active flare, these are the two diets that have been studied the most and found to be the most effective for inducing remission. So the first one is called exclusive enteral nutrition. Exclusive meaning you just drink enteral nutrition, which is that liquid nutrition formula. On the right-hand side of the screen, I have some pictures just to show you examples of some of the formulas we use. There's really no difference in the formulas. They're all effective. The formulas that my patients choose really depend more on their taste preference, their dietary preferences. Maybe they're kosher or they're vegan, or they prefer a non-milk or non-soy based formula. There's lots of options for people to choose from. And so I encourage my patients to try different options and go with the formula that they like to drink, because that will help them be successful with the therapy. So the exclusive enteral nutrition is generally done for anywhere from 6 to 12 weeks in patients with Crohn's disease. It's been shown to induce remission at a rate equivalent to steroids. So in many parts of the world, they actually use exclusive enteral nutrition instead of steroid therapy to induce remission. It's more used in pediatrics because that's where we really want to maximize nutrition and minimize steroid exposure, because steroids can be bad for the bones and bad for growth and bad in so many ways. So if we can spare steroids and use a nutrition formula that also has the benefit of nourishing the individual and helping to promote that growth, that's a benefit for everyone. So that's where it's used the most. It's not used as much in the United States, just because I think providers aren't as familiar with it and they don't have much experience helping people on exclusive enteral nutrition. But here at Cedars, we are able to guide our patients through this therapy who decide to use it. This has been shown, again, to decrease inflammatory cytokines in Crohn's disease. It helps to promote fistula closure. So in complicated Crohn's disease, it's beneficial. And then it's also been shown to serve as a bridge to safer surgery. So if you have complicated Crohn's disease, maybe stricturing or penetrating disease, a recent study showed that 25% of patients who were on EEN before surgery were able to avoid surgery altogether. It has also been shown to reduce risk for stoma formation and reduce risk for infection and surgical complications. So it's really beneficial. I use this a lot in people with Crohn's disease who are actively flaring, or who have complications of their disease, or who need surgery.
How about the UC patient? Is it effective or not?
It just hasn't really been studied in ulcerative colitis. There was a recent randomized controlled trial that showed that people with acute severe ulcerative colitis who did 1 week of exclusive enteral nutrition had a decreased risk for rehospitalization and colectomy 6 months after the acute severe UC episode. More studies need to be done in UC. I think for somebody who's really wanting to use this as their therapy, I don't see the downside, as long as they're able to get enough nutrition. And we have supported patients with UC through EEN if they chose to do that. We just don't have a lot of data on it. Partial enteral nutrition is the other type of formula therapy that we use. And this is where you replace half of your nutrition with formula. So instead of getting all of your nutrition from formula and not having any other food or beverage, you would have half of your nutrition from formula and then the other half from a healthy, balanced diet. This has been associated with lower relapse rates in people with Crohn's disease. So if they're in remission and they add partial enteral nutrition to their therapeutic regimen, they're more likely to stay in remission for longer periods of time compared to people who don't do PEN. It has also been shown to help people increase their odds of achieving remission if they combine partial enteral nutrition with their biologic therapy. So there was a meta-analysis of studies looking at people who were on partial enteral nutrition and starting infliximab, which is a biologic therapy, and the people who were on that combo therapy were they had a twofold increase in the odds of achieving remission. So those are the two places I use it. It's mostly been studied in Crohn's disease, but again, there's no harm to implementing this therapy in somebody with ulcerative colitis who is dedicated and committed to doing the therapy as long as they're being monitored and getting the proper amount of nutrition. And these slides kind of highlight what I just discussed. So EEN is a bridge to safer surgery. On the right-hand side of the screen, you'll see this graph, and it shows you on the left-hand side people on exclusive enteral nutrition. And this is the length of time for the operation. And so on the right side, you'll see no EEN had a longer length of time for operation. And then the bottom bar graph shows EEN on the left side and no EEN on the right side. And these are percentages of patients in each group with complication. So the patients on no EEN before surgery had more anastomotic leaks, more abscesses and collections, higher stoma output, and higher rates of wound dehiscence or wound breakdown. So it can be really beneficial. And this talks about, this is the study that I already talked about for partial enteral nutrition and maintaining remission. So here on the right-hand side of the screen, you'll see this solid line, which is the control group. And then the bottom line, it's kind of dotted, that's the partial enteral nutrition group. And this is looking at rate of relapse over time. And this study was meant to go for 2 years, but they actually ended it early because the treatment group, the partial enteral nutrition group, did so much better than the control group. So they stopped the study early. And this talks about that combination therapy, the PEN, the partial enteral nutrition with infliximab, is found to help people increase their odds of achieving remission and maintaining remission. So moving on to the whole foods diets, I wanted to highlight 3 diets today. So Crohn's disease exclusion diet is the first one. Specific carbohydrate diet is the second one. And then the Mediterranean diet is the third one. So the Crohn's disease exclusion diet, researchers have basically appreciated the fact that exclusive enteral nutrition is very hard to do. It's effective, but it's very hard to drink only formula for 6 to 12 weeks. So researchers from Israel came up with a diet that could mimic EEN, but with getting more nutrition from food and less from formula. And that has been shown to be as effective as exclusive enteral nutrition for inducing steroid-free remission at 6 weeks. So that can be an alternate for somebody who isn't interested in exclusive enteral nutrition but has active Crohn's disease. The second diet, specific carbohydrate diet, has been shown in smaller studies to decrease symptoms, inflammatory biomarkers. It's been studied in pediatrics without a negative impact on growth and has been shown to lead to clinical and mucosal improvements in children with Crohn's disease. We have a larger trial that was done in adults that I'll talk about in a second. It's called the DINE-CD trial, comparing the specific carbohydrate diet to the Mediterranean diet. And then the last diet is Mediterranean diet. So this has been shown to be effective for symptom management, but also helping to decrease inflammatory markers in IBD, in Crohn's, and ulcerative colitis. And it's been shown to help improve pouch function as well. And this is the diet that's kind of more recognized as being generally good for most people with IBD. And it can also have impacts outside of IBD, like reducing your risk for chronic disease and cancer and other cardiometabolic benefits. So let's go through each of the diet in detail. Any question before I move on?
Yes, so for the UC, Mediterranean is better than SCD, basically.
We'll talk about that in a
Oh.
few slides. Maybe I'll describe what the evidence shows. So the first diet, Crohn's disease exclusion diet, remember, this is the alternate to exclusive enteral nutrition. And so this is where you get, it's done in phases. Phase 1 is 6 weeks, phase 2 is 6 weeks, and then phase 3 is like your maintenance long-term phase, which is 9 months or more. So the first phase, you get half of your nutrition from formula and half from foods. The study used a formula called Modulin, which is no longer available in the United States. So for my patients who are doing this diet, we use a comparable standard formula. However, and at the bottom of the slide, you'll see that I bolded this. There was a recent randomized controlled trial that suggests that the formula may not be needed. People were able to achieve the same results without the formula, but with following the diet. So far, the response in the dietetic community is kind of mixed. Some dietitians don't feel comfortable helping patients on the Crohn's disease exclusion diet without the formula because it can be really limited in the amount of variety of foods that people are allowed for the first phase. It's just, there's some concern that it's not nutritionally complete without that formula component. So in the second phase, you decrease your formula need, and then the amount of foods that you can have increases. So you get more foods that you're allowed to eat and more variety. And then the maintenance phase, you continue to get about 25% of your nutrition from formula, with 75% from the Crohn's disease exclusion diet foods. And then you get like 1 to 2 free days per week where you can not have to be as strict with the diet. So how does it work? We hypothesize, we really don't know, but we hypothesize on the left side of this screen, you'll see at the top, it says Crohn's disease exposure to a Western diet. So remember, I talked about this a little bit in the beginning. So we see in studies that when people follow a Western type diet, rich in red meats, animal fats, low in fiber, and high in ultra processed foods, that there's a decrease in their diversity and their microbiome. There's more dysbiosis, meaning more inflammatory microbes and less anti-inflammatory microbes. There's an alteration in their gut barrier function. So you'll see this little green mucus layer on top of the intestinal cells that's like really thin. And then the intestinal cells have these big gaps between them. That's called intestinal permeability, which drives the inflammatory process. So on the right-hand side of the screen, the hypothesis is that the Crohn's disease exclusion diet with these specific components helps to increase that microbial diversity, helps to improve that microbial dysbiosis, meaning that there is more anti-inflammatory versus inflammatory microbes. you'll see that mucus layer is a lot thicker, so there's a lot more protection for the intestinal lining. And then the intestinal cells are closer together, so there's less of that leakiness and intestinal permeability, which decreases inflammatory metabolites and cytokines and helps with healing of the gut. So what are some of the foods that you have to eat? So there's mandatory foods, there's allowed foods, and then there's foods that you cannot have. So the mandatory foods, these are foods that you should be eating every day. These would include bananas, apples, chicken, eggs, potatoes that have been cooked and cooled. And the reason for that is that they have more resistant fiber, which helps to stimulate microbial um, um, it helps to feed beneficial bacteria. And then, of course, the formula. That's a mandatory component on the diet as well. The allowed foods, this is not all inclusive and it does get more liberal as you progress through the phases, but you can have rice, fish, tomatoes, honey, onion, garlic, ginger, cucumber, carrot, spinach, lettuce, avocado, strawberries, melon, almonds, and walnuts. Those are some examples. And then what you cannot have are wheat, dairy, animal fat, food additives. So your ultra processed foods are not going to be allowed in this diet. No red meat, no coffee, no alcohol, no seeds, no artificial sweeteners, and no cocoa. If you're not familiar with it, this is the Gut Friendly Recipes website from the Crohn's and Colitis Foundation. They have like hundreds of recipes that have been vetted by a dietitian, and they have the ability to filter through these recipes if you're on the Crohn's disease exclusion diet, SCD, Mediterranean diet. So I just grabbed some screenshots of the Crohn's disease exclusion diet recipes, and these are some of the examples of foods that people eat when they're on this diet. So who is this diet for? The strongest evidence is for people with mild to moderate Crohn's disease. That's uncomplicated. And it's for pediatrics and adults. The weakest evidence is for those with severe disease, so more complicated, stricturing, penetrating Crohn's disease. But it can be useful as an adjunct to your rescue or bridge therapy, your medications. And it's not recommended for those with eating disorders or those lacking motivation or access to follow this diet. Here are some resources if you want to learn more information about the diet. Modulife, that's basically the company that is associated or affiliated with the diet, and then the Crohn's and Colitis Foundation, and then nt4ibd.org, nutritional therapy for IBD. Moving on to the specific carbohydrate diet, this is a little different. This diet was actually invented in the early 1900s for children with celiac disease, before we knew that the dietary antigen was gluten. This is a completely grain-free diet. It also is low in sugar. The only sweetener allowed is honey. It's basically done in two phases. So the first phase is an intro phase, 5 days. Really limited diet that you follow. Like you can have things like boiled chicken, broiled meats, pureed carrots, homemade gelatin, homemade yogurt. And then you move on to the maintenance phase. You start introducing the other foods at intervals that are recommended by the book. The book is what we recommend all of our patients read who are starting the diet. It's called Breaking the Vicious Cycle, and it was written by Elaine Gottschall. And she kind of popularized this diet. She had a daughter with ulcerative colitis, and her daughter wasn't responding to her medications. And so she put her daughter on this diet, and her daughter did better. And she kind of spent the rest of her life advocating for this diet in the GI community and educating people about its benefits. But this diet is mostly low in disaccharides and polysaccharides, so certain carbohydrates that are hypothesized to drive inflammation and dysbiosis in the gut. So it emphasizes consumption of simple sugars and other foods that are minimally processed. So what's on the menu? What is allowed? Minimally processed meats, poultry, eggs, fish, fruits, oils, fats, nuts, seeds. Certain legumes are allowed and certain vegetables. A big part of the diet is a 24-hour fermented yogurt, which is very easy to make and, in my opinion, very delicious. Aged cheeses and honey is the sweetener that's recommended. And then foods to avoid would be your ultra processed foods, your starchy vegetables like potatoes, garbanzo and pinto beans, soy, chia, flax. Even these foods that you would consider to be healthy are not part of SCD, not because they're not healthy, but because they're just not part of this diet, right? No grains, no dairy, no fruit juice from concentrate, no white table sugar, brown sugar, no chocolate, and no food additives. So here's some examples of the recipes you can make with SCD. A lot of my patients make grain-free breads and pancakes. That can be a big one that's hard to transition away from. But with recipes available and use of things like almond flour and coconut flour, it makes it a lot easier to be on this diet. So the strongest evidence for this diet is in patients with mild to moderate uncomplicated Crohn's disease and ulcerative colitis. So here we're talking about a diet for Crohn's and colitis for children and adults. There is really not a lot of evidence to support it in severe IBD, in extensive and penetrating or stricturing IBD. But if you're following this diet with the support of your team and you're being monitored closely and you're getting enough of the nutrition you need, that's the most important thing. If the diet isn't helping, it's important to have objective markers that you're monitoring over time so that you can pivot or switch therapies if this diet isn't helping. And again, this isn't recommended for somebody with disordered eating or eating disorders or those who lack motivation or access to foods to support them through this diet. And here are some great resources. NIMBAL, this NIMBAL.org was actually developed by a pediatric gastroenterologist at Seattle Children's Hospital. BreakingTheVicious Cycle.info has a lot of information on allowed foods, not allowed foods. There are some companies that make SCD foods and supplements. The gut-friendly recipes from the Crohn's and Colitis Foundation and other information about the diet. And then nt4ibd.org also has recipes and information about this diet. And then here's that study that I was alluding to earlier. So this is called DINE-CD, and this researchers looked at the specific carbohydrate diet versus the Mediterranean diet in people with Crohn's disease. And they randomly assigned them to either SCD or Mediterranean diet for 12 weeks. And then they looked at how they felt, symptoms after 6 weeks, and then some objective markers of inflammation such as fecal calprotectin and CRP. The 12 weeks of one of the diets. After 6 weeks, both diets were equally effective in achieving symptomatic remission. So people felt better on Mediterranean diet or SCD. There wasn't really superiority for either diet. They also had pretty good fecal calprotectin response. 34% and 30% of people on both diets achieved fecal calprotectin response. CRP response was less good there. So the conclusions that the authors made were that the diets are both beneficial for people with Crohn's disease, and if somebody is looking for a diet therapy to add to their therapeutic regimen and they don't want to follow a strict diet, the Mediterranean diet is the next best approach. Now, I will say in the real world, we tend to have patients follow the specific carbohydrate diet for a year or longer. And this study looked at 6-week outcomes, which is pretty quick to assess outcomes after implementing a diet therapy. So just keep that in mind. We do have a lot of patients on both of these diets, and I think they can both be beneficial. They both have different benefits. I think this decision is best made with your team as far as like what diet is best for you. But again, in general, The recommendation from the AGA clinical practice update is that most people with IBD follow like a Mediterranean style diet. And that doesn't mean you have to have like olive oil and hummus and all the foods from the Mediterranean. It's essentially a diet that's mostly plant-based. So incorporating more fruits and vegetables into your diet, regardless of your cultural background, is going to have a benefit for your IBD. So getting more fruits and vegetables, plant-based foods, your nuts and seeds, legumes and grains, more fiber is going to be good. Olive oils are really anti-inflammatory. Um, the diet limits meat and cheese as well as alcohol. But again, you can see the benefits of following a Mediterranean diet extend beyond IBD and can reduce your risk for chronic disease and cancer.
Kelly, I have a question. If somebody did SCD and it is okay, but it doesn't really work, and so is it okay? Is it beneficial to add like some carbohydrate, like rice or potato, just to help? You think it's beneficial as the point that SCD hasn't?
If I can't provide specific advice for specific medical conditions, but I can say that in general, if you're on a diet therapy and you have time points in which you're looking for response, like usually it's 3 to 6 months after starting a therapy, whether that be diet or medications, we want to see what the effect is. Because if you don't have a goal, then you don't have anything that you're comparing it against, right? So starting a therapy and monitoring CRP or sedimentation rate or colonoscopy or ultrasound. And is that improving from the start to the time point in which you're measuring the effect or the response? And if it's not, then considering changing therapies is probably a good idea. But again, this is a discussion that you would have with your team. But usually we like to assess at 3 to 6 months. And if there's no response, then we consider changing therapies, liberalizing away from the approach or changing the diet therapy.
Thank you.
This is newly published in Gastroenterology this year. It kind of describes the mechanistic, how the Mediterranean diet works in people with Crohn's. It's an observational study from Israel. They looked at people who were newly diagnosed with Crohn's disease. And let me just pull up my laser pointer here. So people who were newly diagnosed with Crohn's disease, it was about 280 people, 270 people, and they followed them for 2 years. And they didn't like intervene. They didn't tell them to follow a certain diet. But for the people who were adherent to a Mediterranean diet, IBD med score is how they measured adherence to the Mediterranean diet. Those who adhered to a Mediterranean diet had less complicated Crohn's disease course, decreased disease activity and inflammatory markers. They had more beneficial microbes, less dysbiosis, and less inflammatory metabolites. So they kind of hypothesized that the benefits from the Mediterranean diet might be driven by the changes in the microbiome and the decrease in these inflammatory metabolites that they saw. And before we wrap up, I just wanted to move on to surgery, nutrition in surgery. This is one of the things that I'm most passionate about because many people with IBD will need to have surgery during their lifetime. And people who need surgery often present malnourished or unwell because they've been living with IBD for a long time, or they've had inflammation for many years, or they have complications of their IBD, such as fistulas or strictures. And when you go into surgery malnourished, this can increase your risk for complications. So really, really prime, unique time to address nutrition because it can have huge impacts on your outcomes. So how can we prepare you for surgery better? I think one of the most important things are to assess whether or not you have malnutrition and anemia, because those are independent risk factors for complications. You need more protein before and after surgery. So this is a really opportune time to use those nutrition supplements. maybe talk about nutrition support if you're not able to eat or absorb your nutrition. And then we have something called immunonutrition and carb loading, which are specific surgical shakes or formulas that we use in the immediate weeks around surgery. And these can help to load your body up with nutrients that help decrease inflammation and promote wound healing. And they also can help to preserve your muscle mass and help with your course after surgery, including decreasing your time in the hospital. There hasn't been a lot of study of this in people with IBD. We're looking at it here at Cedars, and our early analysis is showing that these shakes are really beneficial for our patients, leading to less time in the hospital and more preservation of their muscle mass. So these are really good to incorporate in general. And then if you have Crohn's disease, the exclusive enteral nutrition for a few weeks before surgery, again, can really help to decrease complications, but ultimately limiting periods of MPO is really important. I see a lot of people who are not allowed to eat for days before surgery and days after surgery, and that can really delay recovery. So paying attention to nutrition during this time is really important. And then micronutrients, these are really important to check because they do affect your energy levels, your quality of life. Vitamin D and iron are really important to check in everybody, at least annually, more frequently if you have a deficiency. And then B12 is important in those with Crohn's disease, those with an ostomy, or those with pouches. And this just talks about the importance of not only checking hemoglobin for iron deficiency, but looking at ferritin, which is your iron stores, and then transferrin saturation, because you can be iron deficient and not anemic. So we want to look at all of these markers to really assess your iron status. And if you think you may be deficient, it's really good to talk to your team and always, run any supplements that you want to start with your team first, because you may not need it, you may need more of it or less, and we want to make sure you're taking something that's safe for you. So always check with your team. So what you can do, these are 3 things that you can do to advocate for your nutrition. The next time you go see your provider, ask about your nutrition, especially if you feel weak, if you've lost weight, or if you're eating less. You can ask them if there's anything that needs to be looked at as far as your nutrition and your overall health. If you haven't had your labs checked, maybe ask if that's something that they can do, or if something that they need to do. Bone health, people with IBD are at increased risk for osteopenia and osteoporosis. So a bone scan, they're called DEXA scans, are really good to check. Ask to meet with a registered dietitian with expertise in IBD. A registered dietitian in general may not know all the nuances and intricacies of IBD nutrition because we all kind of subspecialize in different areas. So I wouldn't feel like I would give a patient everything that they need if I had to give them diabetes comprehensive education. I would send them to a specialist in diabetes education. So the same as with IBD, you want to go to somebody who knows and is familiar with the disease process and how it impacts the person. And then if you're planning for surgery, ask what you can do to best prepare for that. You may or may not benefit from carbohydrate loading or immunonutrition. And these are things that you can talk about with your team. And that's it. So I have my contact information on the slide. I also have, if you're on social media, my handle there for the formerly Twitter. And then if you want to search for a GI dietitian in your area, iffgd.org, eatright.org, or Crohn's and Colitis Foundation.org all have directories for finding a dietitian. I think the AGA has one now too. So there's lots of places to find somebody to help you.
Thank you so much, Kelly. That was really fantastic. And you touched on so many things that are really important. Do you have time for any questions? I know you had to go, but
yeah, I can see
some questions that were submitted in the registration. So I'll just ask a few of them. you talked about foods not to eat, during a flare, but what about sugar in general?
Sugar in general, so we want to make sure the diet is balanced. So sugar isn't bad, right? It's not harmful, it's not toxic. Anything in excess is not going to be good for you. So sugar kind of has been villainized in social media and the lay press, but in moderation is fine. A lot of these nutrition formulas that I'm talking about, sugar is going to be high in them, and that's because they're the liquid equivalent of carbohydrates. Our bodies need a lot of carbohydrates for brain function and muscle preservation and energy. And so that's going to be the majority of the calories, but it's also blended in there and balanced with proteins and fats. So the balance is what you want to be looking for overall.
Okay. Someone put a question in chat about bloating, and we had a question about that, which also maybe piggybacks a little bit on fermented foods, which you touched on not to have when you have a flare, but in general, like kombucha and other fermented foods. And what about bloating?
I like to encourage people to eat fermented foods. I think they're really beneficial for our health. We want to really look at what's driving that bloating. Sometimes it can be related to strictures, right? And so modifying the texture of your food can really help to decrease bloating. Sometimes it can be related to constipation, in which case you might need a little more insoluble fiber to get things moving along. Sometimes just imbalanced diet or not enough variety or diversity in the diet to support that healthy microbiome balance. But I would try fermented foods. In some people, that can worsen symptoms initially or just in general. Like, if, for example, you have SIBO or small intestinal bacterial overgrowth, you may not want to add more microbes to your intestines because there's already too much in your small bowel, and more is just going to ferment more food and make you more bloated. So, this is really a question that you should take to your provider, dietitian, to really understand if that's the right move for you.
Okay. And also, what about supplements? I mean, someone put in the chat Cure QD, which I'm sure you know what that is, but then also like turmeric and fish oil. And does fish oil cause the blood to thin?
Yeah, so let me talk about the fish oil and turmeric first. They can increase thinning of the blood. So for my patients who are menstruating, it can make their bleeding worse. Patients who are like preparing for surgery, we want to stop those supplements before surgery. So that's something to consider. You also don't want to take those if you're planning to, or if you are pregnant. So always check with your provider first. CurQD is a curcumin supplement along with an herbal anti-inflammatory called Qingdai, and that has been shown to help decrease inflammation in people with IBD. So there's a specific regimen that you follow on that supplement, and the manufacturer's website like sets you up with the right dosage based on how you're feeling. You don't want to be on Qingdai for very long because it can increase your risk for pulmonary hypertension. So if you're on that regimen, the Qingdai slowly decreases as you're progressing through the phase of your disease activity. So it's just something to keep in mind.
Okay, thank you. What about smoothies, even though, they just have fruit in them? Is that too much sugar and fiber maybe for, just having that as a meal?
That's a great question. So with smoothies, I always encourage people to add different things to smoothies, because if you just have fruit in a smoothie, you're going to end up having like a lot of fruit. And sometimes that can worsen bowel movements. If you're having diarrhea, lots of fruit, lots of sugar can worsen that. If you're constipated, that might be helpful. So I recommend one fruit serving if you're having a smoothie, maybe two fruit servings, and then try to throw in some veggies, maybe some leafy greens if you're comfortable with that, or some nuts or seeds. That blender is going to break everything down into really small particles, make it a lot easier for you to digest that. And the other components are going to be lower in sugar and help with metabolism and satiety and all of those other benefits that we see with a balanced diet. So I would avoid all fruit smoothies and aim for like the balanced ones with other components.
Got it. And then this is like a $1 million question. Do you have, do you know, do you see people who basically just control can go into remission basically just by diet alone? I know that some people with the exclusive enteral nutrition or partial have used that and they, have treated their disease very well. But what is in your observations?
The Crohn's disease exclusion diet versus
No,
EEN.
no, just using diet alone to treat your IBD.
So that is a really personal thing. I will say that in my experience, most people need some sort of low dose medication on board to help with controlling disease activity. Even if you start a diet and it gets you into remission, you have to remember that the IBD is a complex multifactorial process and it involves many factors that trigger that flare. Diet is only one part of that puzzle. There's also your microbiome and your immune system and your genetics that kind of prime your body for that inflammatory process. So it is rare. I do have some patients just on diet therapy alone with like very mild disease. But the majority of my patients on diet therapy kind of use it in combination with other agents to help with getting into or maintaining that remission long term. But the checkups, the colonoscopy, the fecal calprotectin, the labs, those are going to give you objective information that tells you about your disease activity, not just feeling well on the diet, but knowing that those deeper layers of remission are in place as well.
Yes. Well, thank you very much. We don't want to take up too much of your time. I know there are some other questions, but hopefully we'll have a resource available for that. And I just want to thank you so much for being here tonight and teaching us all about diet and IBD because it's really important. And I think people don't realize it. And like you said about not just treating symptoms, but making sure that, it's also helping with healing of your gut. So appreciate that.
You're welcome. And please feel free to reach out if you have any questions, reach out on social media or by email. I'm happy to help.
Thank
Okay.
you. Can we have a recording of tonight?
Yes, we can send it to everybody.
Thank
Thank
you so
you.
much. Thank you.
Thank you, everybody.
Thank you, Kelly.
You're welcome. Thanks, everybody.
Bye. Thanks.
Thank you. Thank you.
Yeah.
Carmen,